We all take our kidneys for granted, but they have an essential role in maintaining homeostasis. The kidneys are like the gatekeepers of the bloodstream. They filter waste products out of the blood while retaining substances that the body needs. As you recall, this elegant process, better known as selective filtration, starts at the glomerulus. If the glomerulus becomes damaged, either due to a primary glomerular disease or a systemic disease that affects the glomerulus, its permeability can be altered, causing inappropriate excretion of macromolecules in the urine. Nephrotic syndrome is a clinical syndrome that's caused by damage to the glomerular basement membrane, leading to altered permeability of the glomerulus. And in this scene, we've recreated the glomerular basement membrane at Hadrian's Wall. Did William Wallace actually fight the English at Hadrian's Wall? Probably not. Is the First War for Scottish Independence the perfect setting to learn about nephropathy? You bet your proteinaceous pea it is. The nephrotic syndrome is defined clinically by a triad of heavy proteinuria, hypoalbuminemia, and peripheral edema. It's a classic condition that every medical student must be able to recognize clinically, and since exam writers love it, it's also a favorite nephrology topic on board exams. So, in this video, we'll cover the clinical presentation, diagnosis, and management of nephrotic syndrome. Feel free to use the nearest restroom now, because we'll be talking about urination pretty much the entire sketch. I can wait. Altered permeability of the glomerular filtration barrier leads to increased filtration of proteins into the urine, resulting in heavy proteinuria. This protein is comprised mainly of albumin, but also includes anticoagulant factors, especially antithrombin, transferrin, immunoglobulins, hormones. It's like a protein party in there. Over time, the massive amount of albumin lost in the urine depletes albumin levels in the blood beyond the synthetic ability of the liver, which causes hypoalbuminemia, as depicted by that depleted picture album. Enter King Edward I, also called King Edward the Edematous. Don't quote me on that. Needless to say, hypoalbuminemia lowers plasma oncotic pressure, causing fluid to shift into the interstitial space. Due to the decreased intravascular volume, renal sodium retention is increased. As a result, edema and effusions are cardinal features of nephrotic syndrome. Nephrotic syndrome can be caused by either primary glomerular disorders or systemic disorders. Focal segmental glomerulosclerosis, for example, has both a primary or idiopathic form, as well as secondary forms associated with drugs, toxins, viral infections, and even obesity. Glomerulosclerosis describes the hyalinization and obliteration of glomerular capillaries, and this occurs focally, i.e., only in some glomeruli, and segmentally, i.e., only parts of each glomeruli are affected. Minimal change disease is the most common cause of nephrotic syndrome in children. Hence this protester kid here telling King Edward to suck it. Minimal change! Minimal change! Minimal. Okay, I'm not gonna lie, I think we need a more effective slogan for the Scottish independence movement. Anywho, keep in mind that minimal change disease can be seen in adults too. It most commonly occurs as a primary idiopathic disease, but can also occur secondary to drugs, neoplasms, infections, and even allergies. Another common cause of nephrotic syndrome in adults is membranous nephropathy, illustrated here by the long membranous cape, which depicts the characteristic basement membrane thickening. It too mostly occurs as a primary idiopathic disorder, but can also occur secondary to drugs, hepatitis B infection, and malignancy. Nephrotic syndrome can also be caused by systemic diseases that affect the glomerulus. Renal amyloidosis is a more common cause of nephrotic syndrome in older individuals. And what do you know? It's our amyloid armored lady, here to kick some English glomeruli, so to speak. AL, or primary amyloidosis, is associated with monoclonal gammopathies, and AA, or secondary amyloidosis, is associated with chronic inflammatory diseases. Both etiologies involve abnormal deposition of proteins in the mesangium and capillary loops of the glomerulus, depicted here by the aggregate of chainmail ringlets deposited on her torso. Release the lupus wolf! Renal disease, including nephritic and nephrotic syndrome, is common in patients with systemic lupus erythematosus. Of the 6 different classes of lupus nephritis, focal lupus nephritis, aka class 3, diffuse lupus nephritis, class 4, and lupus membranous nephropathy, class 5, typically present as nephrotic syndrome. Holy HbA1c! The English weren't joking when they said they were pulling out the big guns. Candy, of course, is our symbol for diabetes. Diabetic nephropathy is associated with albuminuria, sometimes hematuria, and progressive chronic kidney disease. Moderately increased albuminuria, and by that I mean 30 to 300 milligrams per day, is an early sign of diabetic nephropathy. More advanced disease can progress to nephrotic syndrome, especially in those with poor blood pressure and glucose control. All right, next, let's illustrate the typical presentation of nephrotic syndrome. Because of high urine protein levels, some patients report having frothy urine. Remember this tip, because frothy urine in the proper clinical context is always a buzzword for nephrotic syndrome on exams. Edema is the main clinical feature of nephrotic syndrome. Patients can present with lower extremity swelling due to dependent edema, particularly pedal edema. Patients may also report swollen eyes due to periorbital edema, which is often present when awakening in the morning. Tissue turgor is low in the periorbital space. So that's why you'll often see the swelling show up, just like the sleep mask on the Queen. Patients may also present with abdominal distension from ascites. This typically only occurs in patients with severe anasarca. Weight gain is very common because patients retain large amounts of fluid. Weight is commonly used to monitor treatment efficacy, so a weight history can be useful in defining treatment parameters. Edema of the GI tract can cause anorexia or vomiting, yet, despite a decreased appetite, patients continue to gain weight because of all that aforementioned third spacing and fluid retention. In nephrotic syndrome, clotting factors such as antithrombin and protein C and S are lost along with albumin in the urine, leading to a hypercoagulable state. As a result, nephrotic syndrome is associated with arterial and venous thrombosis, most commonly renal vein thrombosis and DVT, along with associated pulmonary embolism. In particular, the risk of renal vein thrombosis is highest with membranous nephropathy, which is why we've given this infarcted kidney soldier a matching membranous cape. Renal vein thrombosis is usually chronic and asymptomatic, marked only by gradually worsening renal function. Renal vein thrombosis can occur acutely, however, and presents with symptoms of renal infarction, such as flank pain and either microscopic or gross hematuria. Furthermore, the loss of immunoglobulins in the urine also makes patients more susceptible to infections, especially encapsulated bacteria like pneumococcus. So let's add in our recurring bacterial lantern symbol, along with some encapsulated foodstuffs. Stop the battle, everyone! Time out. Snack time. The presence of chronic effusions, such as ascites and pleural effusions, also provides a nice moist environment for bacterial growth, thus setting patients with nephrotic syndrome up for spontaneous bacterial peritonitis or empyemas. Alright, let's get into some past medical history. Obesity is a risk factor for the focal segmental glomerulosclerosis pattern of nephrotic syndrome. Typically, these patients will experience improved renal function with weight loss. HIV infection is also commonly associated with focal segmental glomerulosclerosis. Notice that we've emphasized HIV over at the focal segmental table with our usual white wizard hat. You remember the evil HIV wizard from Sketchy Micro, right? Taking down those CD4 cells with his dark magic and whatnot? You'll meet him again later on in our infectious disease unit. Hepatitis B and C are also associated with membranous nephropathy, so let's add in some sweet hepatitis hippo headgear to the membranous knight's horse. Solid tumors, such as lung, colon, prostate, and breast cancer, can also lead to membranous nephropathy, hence the cancer crab symbol on his chest. Hematologic malignancies, particularly lymphoma, can lead to nephrotic syndrome, often the minimal change disease variety. So we've added our recurring symbol for lymphoma, a chessboard. Think of a chessboard as a lymph node, where white cells of all types like to hang out and rub up against each other, in a platonic kind of way. Those antibody archers, of course, represent a proliferation of mutant B cells. And since we're on minimal change disease, here's an interesting fact. Up to 30% of affected patients have a history of atopy, aka allergies. This includes allergies to fungi, poison, ivy, grasses, dust, cat fur, even bee stings. In fact, nephrotic syndrome can actually be triggered by an allergic reaction in these patients. Nephrotic syndrome due to amyloidosis can be seen in multiple myeloma and other monoclonal gammopathies due to deposition of clonal immunoglobulin light chain fragments. This is known as primary or AL amyloidosis. Think of the monoclonal gammopathies as this immunoglobulin archer. Skeleton themed because the abnormally active plasma cells creating all that extra immunoglobulin reside in the marrow. Chronic inflammation during rheumatologic disease or chronic infections, for example, can result in an amyloid renal disease as well. This is referred to as AA, or secondary amyloidosis. The most common cause is rheumatoid arthritis. So we've added our usual inflamed joint lanterns to the scene. Keep in mind that other inflammatory conditions can cause AA amyloidosis too, including ankylosing spondylitis, psoriatic arthritis, IBD, and chronic pyogenic infections. As we mentioned earlier, lupus is an important risk factor for nephrotic syndrome and can present with a range of renal biopsy findings. Renal failure in lupus is an important cause of morbidity and mortality, and patients with lupus will often undergo frequent renal function testing. Keep an eye out for other features of lupus, such as malar rash, arthralgias, or pleuritis, discussed in detail over on our Lupus Teen Wolf sketch. And back to diabetes. Diabetic nephropathy initially presents with microalbuminuria, which means 30 to 300 milligrams per day. Risk factors for progression from moderate to severe albuminuria and even nephrotic range proteinuria include poor glycemic control, as measured on the hemoglobin A1C, and poor blood pressure control. So we've made sure to add lots of elevated candy, as well as some high pressure steam. Severely increased albuminuria is usually followed by a progressive decline in GFR. Next, let's check those medications. Turns out a whole range of medications are associated with nephrotic syndrome, typically the membranous, minimal change, and focal segmental varieties. So we've added a home meds bag to the scene next to our minimal change kid, membranous mountie, and focal segmental strategists. Culprit medications include captopril, penicillamine, antibiotics, lithium, interferon, and biphosphonates. The use of NSAIDs is also associated with the development of nephrotic syndromes, most commonly minimal change disease or membranous nephropathy. So we've brought in our recurring NSAID symbol, the inflammation extinguisher, the perfect weapon for thwarting a Scottish invasion. As we illustrated in the previous video, however, NSAIDs more commonly cause acute interstitial nephritis rather than these nephrotic conditions. Head on over to our Mega King AKI sketch for all the greasy, overpriced details. Alright, time to get touchy-feely. When picturing the physical exam of patients with nephrotic syndrome, just think edema. That's because the protein loss and fluid retention of nephrotic syndrome leads to a dependent edema state. The edema will flow with gravity to the most dependent point of the body, which can be the periorbital region early in the morning, lower extremities in ambulatory patients, or sacrum or scrotum in bedbound patients. In particular, expect pitting edema, which is defined as a persistent tissue depression for at least 5 seconds after release of pressure applied to the edematous area. Patients with massive, long-standing edema develop anasarca, which appears as a widespread swelling of the skin due to effusion of fluid into the extracellular space. Chronic anasarca can give the skin a tough, woody appearance. On lung exam, you may hear decreased breath sounds and dullness to percussion at the lung bases. That's because patients can develop pleural effusions, as illustrated by that wet pleural shirt. These effusions will be transudative. On abdominal exam, patients can have ascites, evidenced by abdominal distension, shifting dullness, and the presence of a fluid wave. Some patients with nephrotic syndrome can develop acute kidney injury, manifesting as an elevated BUN and creatinine. Or in the sketchy universe, an elevated BUN fast food bag with creatinine credit card. AKI is more likely to develop in the setting of extreme proteinuria and hypoalbuminemia, i.e., more severe disease. The workup for patients with suspected nephrotic syndrome begins with a 24-hour urine collection to quantify the amount of proteinuria. Normal individuals excrete less than 150 milligrams of protein per day in their urine. A urinary protein excretion greater than 3.5 grams per day is diagnostic for nephrotic range proteinuria. An alternative means for quantifying proteinuria is a spot urine protein to creatinine ratio, as embodied by Spot here, holding that protein leg while surfing to safety on what looks like. Is that a credit card? You know what? Who cares what that is? He's frickin' surfing! I mean, where is that momentum coming from? A spot urine protein to creatinine ratio closely correlates with a 24-hour urine protein. A ratio greater than 3.5 is consistent with nephrotic range proteinuria. This may be preferred in patients who are unable to reliably collect 24 hours of urine. On urinalysis, don't expect much. Typically, few cells or casts are seen. However, fatty casts may be seen due to high levels of lipiduria and are highly suggestive of nephrotic syndrome. These lipids can be entrapped in casts, aka fatty casts, or they can be enclosed by the plasma membrane of dead epithelial cells, at which point they're called oval fat bodies, just like the oval fat bodies of these escaping pigs. Patients should also have their serum albumin levels checked to assess the degree of hypoalbuminemia, a cardinal feature of nephrotic syndrome. Patients with nephrotic syndrome will have less than 3 grams per deciliter of albumin. Patients with nephrotic syndrome often have hyperlipidemia. Weird, right? Apparently, the decreased oncotic pressure stimulates the production of lipoproteins by the liver. And on top of that, there's a decreased clearance of lipoproteins. Lipoproteins are the vehicles for cholesterol, remember? So, hypercholesterolemia, here we come. It's not entirely clear why decreased oncotic pressure elicits this response, because lipoproteins are not that great at increasing oncotic pressure. Hypertriglyceridemia can be seen as well. This is mainly driven by increased renal albumin excretion. Again, not really sure why this happens. In patients with suspected diabetes, obtain a hemoglobin A1C. In patients older than 50 years, you should be especially concerned for multiple myeloma. Check serum free light chains and serum and urine protein electrophoresis in this age group. Certain serologic tests can be obtained, in the proper context, of course. If lupus is suspected, ANA, anti double stranded DNA antibody, as well as C3 and C4 levels can be checked. Complement proteins will be low in the setting of active lupus nephritis. If history and clinical presentation point toward HIV or hepatitis B and C, patients should receive testing. In the past, a kidney biopsy was the only way to definitively diagnose membranous nephropathy. How about today? Well, now we do serologic testing first. Patients suspected to have membranous nephropathy should receive testing for anti-PLA2R antibodies, which are autoantibodies directed against podocyte transmembrane proteins. Whoa, Edward hired the Knights Templar? Aren't they all retired now? Negative anti-PLA2R antibody doesn't rule out membranous nephropathy, by the way. Some cases are seronegative. Unless there's an obvious etiology, like long-standing diabetes, most patients with nephrotic range proteinuria undergo renal biopsy to determine the underlying histology, which guides management decisions. So William Wallace is brandishing our recurring symbol for biopsy, that grabby reaching tool thingy. Hey, don't laugh. Wallace is deadly with that thing. Grab your face off. Let's look under the microscope, shall we? Focal segmental glomerulosclerosis appears just like its name. As we described earlier, glomerulosclerosis describes the hyalinization and obliteration of glomerular capillaries. And this occurs focally, i.e., only in some glomeruli, and segmentally, i.e., only parts of each glomeruli are affected, as illustrated by Wallace's battle plans on the table. We've made Robert the Bruce here crumpling one of the glomerular battle plans to highlight a special form of FSGS, also known as the collapsing variant. Instead of segmental involvement, there's a total collapse and sclerosis of the involved glomeruli. This form of FSGS is associated with HIV, symbolized by that HIV wizard hat. Minimal change disease is given the title of minimal change because the glomeruli appear normal on light microscopy, though damage to the epithelial cell foot processes, such as podocyte fusion, is visible on electron microscopy. It's suspected that it may be secondary to T cell dysfunction and production of a glomerular permeability factor. Another pattern of nephrotic syndrome in adults is membranous nephropathy, which appears histologically as diffuse basement membrane thickening in all glomeruli, as illustrated by his cape lining the wall. With special staining, you'll classically find spikes of basement membrane expanding around immune deposits. Under fluorescence microscopy, membranous nephropathy displays a diffuse granular pattern of IgG and C3 along the basement membrane. Kind of like this diffuse and granular fluorescent moss along the wall, actually. How about renal amyloidosis? It's pretty unique, actually. Light microscopy reveals glomerular deposition of hyaline material that stains positively with Congo red. which is why our armored lady is stained with red. These deposits will display apple green birefringence under polarized light, hence the apple green smoke coming from those apple bombs. Immunofluorescence will generally be positive for lambda or kappa light chains in primary AL amyloidosis associated with monoclonal gammopathies. Immunofluorescence is frequently negative in secondary AA amyloidosis associated with chronic inflammation. Diabetic nephropathy manifests as basement membrane thickening and nodular glomerulosclerosis. The characteristic lesions of nodular glomerulosclerosis are called the Kimmel-Steele-Wilson nodules, which show up on light microscopy as round deposits of laminated mesangial matrix. And sclerosis means you'll see obliterated capillaries with hyaline deposition. As for the differential diagnosis, remember that from our glomerulonephritis sketch, that membranoproliferative glomerulonephritis can also present with nephrotic range proteinuria. Let's go over a few features of MPGN that can distinguish it from nephrotic syndrome. For more details on MPGN and other causes of nephritic syndrome, check out our glomerulonephritis SOAP sketch. First of all, nephritic syndrome commonly presents with hypertension and renal impairment. Secondly, the UA will show hematuria, dysmorphic RBCs, and RBC casts in patients with glomerulonephritis. You may see low C3 and C4 in immune complex mediated MPGN, while low C3 and normal C4 is typical of complement mediated MPGN. On light microscopy, look for a thickened GBM and so-called tram tracking of the GBM. There is also increased mesangial cellularity, leading to a lobular appearance of the glomerulus. On fluorescence microscopy, immune complex mediated MPGN exhibits positive staining for immunoglobulin and complement. Complement staining MPGN will stain positive for predominantly complement. Surprising, I know. A special subtype, called dense deposit disease, exhibits linear deposits of electron dense material in the GBM on electron microscopy. Let's sum up everything we've learned so far with a summary statement. Mr. Wallace is a 56-year-old man with a history of diabetes and colon cancer who presents with 1 month of fatigue and periorbital swelling. He also reports that his urine has had a foamy appearance for the past week. His physical exam is notable for periorbital edema, decreased breath sounds, dullness to percussion at the left lung base, and 2+ pitting edema of the lower extremities. His urinalysis demonstrates the presence of fatty casts. The remainder of his labs are notable for a 24-hour urine protein excretion of 4.2 grams and a serum albumin concentration of 2.8 grams per deciliter. Overall, his clinical picture is consistent with nephrotic syndrome. Once you've made the diagnosis of nephrotic syndrome, it's time to start treatment. First-line therapy for treating edema includes loop diuretics and a low-sodium diet for fluid removal. Other diuretics may be necessary for synergistic effect. Patients should also receive an ACE inhibitor or ARB. These agents reduce intraglomerular pressure and can be useful to reduce proteinuria. Once kidney biopsy results are known, you can use more specific therapies based on the underlying cause. For minimal change disease, glucocorticoids are the treatment of choice, leading to complete remission of proteinuria in over 85% of cases. At Sketchy, we always depict glucocorticoids with that eerie moon face, reminiscent of the moon faces experienced by patients on long-term systemic glucocorticoid therapy. And in this scene, we've got moon cannonballs being hurled from the Scottish lines. Focal segmental glomerulosclerosis can be treated with glucocorticoids alone, but requires a more prolonged course. You can treat with other immunosuppressive therapy with or without low-dose glucocorticoids. Membranous nephropathy resolves spontaneously in many patients with mild to moderate disease. Therefore, this population is treated supportively. In patients with more severe disease, glucocorticoids plus another immunosuppressive drug is first line. Hyperlipidemia caused by nephrotic syndrome increases the patient's risk of atherosclerosis. Although studies of the effects of dyslipidemia in patients with chronic nephrotic syndrome are limited, these patients are most commonly treated with a statin. Dyslipidemia usually improves with improvement of the renal disease. That about does it for the clinical presentation, diagnosis, and management of nephrotic syndrome. Let's draw and quarter this sketch into a few important points. The diagnosis of nephrotic syndrome is based on a triad of urinary protein excretion greater than 3.5 grams per day, hypoalbuminemia, and edema. Patients also frequently develop lipiduria, hyperlipidemia, venous thrombosis, and frequent infections. The classic presenting symptoms of nephrotic syndrome include weight gain, leg and eye swelling, abdominal distension, and frothy urine. The most common cause of nephrotic syndrome in children is minimal change disease. Focal segmental glomerulosclerosis and membranous nephropathy comprise most cases in adults. Lupus nephritis, diabetic nephropathy, and amyloidosis are important risk factors for nephrotic syndrome. The most important exam findings to watch out for include periorbital edema and peripheral edema. Patients commonly develop ascites and pleural effusions as well. If your patient presents with these signs, it's time to confirm the diagnosis with a 24-hour urine collection. In nephrotic syndrome, it will show greater than 3.5 grams of urinary protein excretion per day. A spot protein to creatinine ratio can be used as well. You should also analyze the urine sediment, which may show fatty casts or oval fat bodies. Depending on the clinical setting, serologic testing can be used to assess for conditions associated with nephrotic syndrome. Test for HIV, a cause of FSGS. Also test for Hep B and Hep C viral serologies, which may be positive in membranous nephropathy. Look for ANA, anti-double stranded DNA antibodies, low C3 and C4 in patients with suspected lupus. Check for serum free light chains and perform a serum and urine electrophoresis if you suspect multiple myeloma. Check hemoglobin A1C in suspected diabetics. Kidney biopsy is often required for definitive diagnosis. The treatment of nephrotic syndrome begins with diuretics and sodium restriction to reduce edema, and an ACE inhibitor or ARB to reduce proteinuria. Glucocorticoids are the mainstay of treatment for minimal change disease. For FSGS, glucocorticoids are the initial treatment as well, resolve spontaneously in many patients with mild to moderate disease. Therefore, this population is treated supportively. In patients with more severe disease, glucocorticoids plus another immunosuppressive drug is first line. All right, on to nephritic.